Değerli meslektaşlarım, bir ACS webinarına hoş geldiniz. Bugünkü konumuz oldukça güncel ve klinik pratikte çok karşımıza çıkan bir soruya cevap arayacak. Cerrahiye giden ilaç kaplı stent takılmış hastalarda antitrombotik tedaviyi nasıl düzenleyeyim? Moderasyonda Profesör Doktor Mutlu Vural var, bana eşlik edecek. Yayınlanan, biliyorsunuz ESC'de sunuldu. Eş zamanlı olarak da JAC'ta yayınlanan Götürüelecek çalışmasının Türkiye'deki baş çalışmacısı. And the great surprise of the day is the primary investigator of the Götürüelecek trial. Dr. Jung-Min Ahn is with us. The first presentation is from Dr. Vural. Please Mutlu, you can go on.
Teşekkür ediyorum. Ben sırt dışı cerrahide özellikle ilaç salınımlı stent kullanılan ve 12 aydan önce cerrahi yapılan olgularda antiplatelet ve antikoagulant tedavinin yönetimini anlatacağım. Gerçekten bu tür hastalarda öncelikle kanama riskini belirlememiz gerekiyor. Tabii ki bu cerrahiye göre değişiyor. Yine aldığı tedaviye göre, hastanın özelliklerine göre değişiyor. Aynı zamanda biz en çok ikili antiagregan alan hastada kalp dışı cerrahi nedeniyle antiagregan tedaviyi kestiğimizde antiplatelet tedavi, stent tromboz, ama bunun yanında venöz tromboembolik, yine fibrilasyon olan, aynı zamanda prostatik kapak hastalığı olan hastalarda arteriyel tromboemboliyi de değerlendirmemiz gerekiyor. Eğer biz hastalarda mevcut çok rahat bizim için. Bundan dolayı rahatız. Kesmemiz gerekiyorsa, yine bir biliş tedavisi gerekiyorsa burada işler daha kompleks hale geliyor. Stent hastalarında iskemik komplikasyon oranlarında burada klinik işlemsel faktörler devreye giriyor. Çok damar hastalığı, diyabet, kalp yetmezliği, böbrek yetmezliği, yatarak tedavi, yine akut koroner sendrom nedeniyle PCI olması klinik olarak iskemik olayların artacağını gösteriyor. Yine RC-RA skoru, bunlar aşağıda belirtilmiş 6 tane skorlaması var. Bu da yine klinik özellikleri gösteriyor, artmış iskemik riski. Prosedürel olarak 3 damar hastalığının tedavi edilmesi, 3 ve daha fazla stent kullanılması, 3 ve daha fazla lezyonun tedavi edilmesi, bifurkasyon lezyonun 2 stent uygulanması, total stent uzunluğunun 60 mm'den uzun olması, düzene müdahale, osteal ya da distal girişimler, solana koroner girişimler, kalsifiye lezyonlar, yine uzun hedef damar lezyonları işlemsel riski oluşturmakta iskemik açıdan. Bir hasta karşımıza geldiğinde gerçekten trombozla kanama arasında arada kalıyoruz. Yani antiagregan alanlarda aşağı tükürsen sakal, yukarı tükürsen bıyık misali. Yine hastayla işlemi değerlendirmemiz gerekiyor. İşte prosedürün kaçıncı gününde, özellikle ilk 60 günde ikili antiagreganı kesmek zor oluyor. Yine her zaman şeyi unutmamamız lazım. Yani bizim hastalarımız ikili antiagregan tedavi alıyor ama bu hiçbir zaman antikoagulant tedavinin yerine geçmez. Mutlaka risk skorlamasıyla venöz tromboemboli riskini değerlendirmemiz, ona göre tedbir almamız gerekmektedir. Bunu ihmal etmemeliyiz. Şimdi 2 hasta örneği vereceğim size. Katarak ameliyatı oldu. Tek hasta alt kapak replasman olmuş 10 yıl önce. LAD'ye DES implantasyonu var 5 ay önce. Klopidogrel ve varfarin alıyor. Aspirin kesilmiş. Kronik akciğer hastalığı var. Hipertansiyonu var. Diğer hastamızda, ikinci vakamızda DES uygulanan hasta 4 ay önce ikili antiagregan tedavi alıyor. Diyabetik, hipertansif. Bu hastaların katarak ameliyatından önce nasıl yönlendirilir? Çok sevindirici bir şey. Lens, doğal lensimiz avasküler bir yapı. Aynı zamanda kornea da avasküler yapı. Bizim bu hastalarda ne antikoagulant tedavi ne antiagregan tedavileri kesmemiz gerekmiyor. Tedaviler devam ederken işlem yaptığımızda da iskemik riskler oldukça düşük oluyor. Aynı hastayı biz diş operasyonla, ki bunlar bizim poliklinikte en çok karşımıza çıkan hastalar, dişle ilgili bize gönderildiğinde ne yapacağız, nasıl yöneteceğiz antikoagulan ve antiagregan tedaviyi? Aynı hastalar olduğu için bunu geçiyorum. Diş ameliyatlarında kanama riski oldukça düşük. Bu nedenle eğer iğneyle varfarin kullanan hastada terapötik aralıktaysa bizim tedavi kesmemiz gerekmiyor. Hem varfarine devam ediyoruz hem böyle devam ediyoruz. Ama diş hekimine diyoruz ki lokal önlemlerini alıyoruz. Onların gerçekten çok güzel şeyleri var. İçinde adrenalin olan preparatlar var. İşte kompresyon, dikişle bu tür önlemleri alıyoruz. Diğer hastada da aynı şekilde ikili antiagregan tedaviyi kesmeden, çünkü kanama riskimiz oldukça düşük, hastayı diş hekimine gönderiyoruz. Bu 2 hasta grubu gerçekten çok sevdiğim hasta grupları. Çünkü tedaviyi değiştirmiyoruz. Peki atrial fibrilasyonu var. Apiksaban alıyor ve inguinal hernia operasyonu için bize gönderildi. Ve bir ay önce de DES uygulanmış anakoroner için. Bu hastada ne yapacağız? İlk 60 günde olduğu için çok riskli hasta grubu. Bu tür hastalarda ameliyatı, inguinal hernia ameliyatı çok acil bir ameliyat olmadığı için erteleyebildiğimiz kadar erteliyoruz. Ertelemenin sonunda hasta geldiğinde gerçekten bu yeni nesil antikoagülanlarla ilgili işte ameliyattan 2 gün önce mi, 3 gün önce mi, 5 gün önce mi kesmeliyiz? Nasıl bir bridge yapmalıyız? Yine hemen ameliyat gününde biz NOAC seviyelerini ölçmeli miyiz? Türkiye'de yok ama yani yurt dışında bu tür tartışma. Gerçekten çok kompleks bir konu. Çok farklı ilaçlar var, çok farklı ameliyatlar var, kalp dışı ameliyatlar. Hasta özellikleri farklı. Pek çok konuyu bilmiyoruz ve sınırlı sayıda kanıt var. Öncelikle farmakolojiyi bilmek lazım ama farmakolojide de gerçekten farklı. Mesela aspirinin 3 saatlik yarı ömrü var ama etkisi çok uzun sürüyor. 7-10 gün önceden kesmek gerekiyor. Yine apixaban, rivaroxaban yarı ömrü 8-15 saat 2-3 gün önceden kesmek gerekiyor. Bu özelliklerin hepsini hasta özellikleriyle birlikte, operasyon özellikleriyle birlikte değerlendirmemiz gerekiyor. Yine varfarini ameliyattan 5 gün önce kesiyoruz. İğne 1,5'un altına indiğinde bridge yapıyoruz. Ameliyat öncesi bridge. Sonra ameliyatı yaptıktan sonra yine postoperatif bridge yaparak kanama kontrolünün sağlandığı zamanda, en erken zamanda varfarini başlıyoruz. Varfarin etkin olana kadar da düşük molekül ağırlıklı heparine devam ediyoruz. NOAC'larda prop bridging gerekmiyor. NOAC'ın şekline göre böbrek fonksiyonunu kesme süreleri var. Örneğin dabigatran'da böbrek fonksiyonları bozulursa 5 gün önceden kesmek gerekiyor. Onlar ilaca göre değişiyor. Ameliyatı yaptıktan sonra yine düşük molekül ağırlıklı heparinle bridge yapıyoruz. Kanama kontrolünden emin olduğumuz zamanda da 1-3 gün içerisinde de tekrar tedaviye başladığımızda bridge'i kesiyoruz. Varfarin gibi overlap yapmıyoruz. Antiagregan tedavi alan hastada nasıl bridge yapacağız? Bu çok önemli. Prasugral'ı 7 gün önceden kesiyoruz. Ticagrelor'ı 5 gün önceden kesmemiz gerekiyor. Türkiye'de genelde uygulamamız düşük molekül ağırlıklı heparinler. Bunları kestiğimizde bridge'i o şekilde yapıyoruz ama artık Cangrelor, IV antiviral, çünkü bu kestiklerimiz antiplatelet tedavi ve bunun yerine Cangrelor varsa o, yoksa eptifibatit ya da trofiban kullanmamız gerekiyor. Ameliyatı yaptıktan sonra da tekrar yükleme yaparak antiagregan tedavimize devam ediyoruz. Eğer kanama kontrolünden emin değilsek bir süre daha IV antiagregana devam ediyoruz ama bunlar dediğim gibi çok net değil ve tamamen uzman görüşüne dayanıyor. Kanıtlarımız son derece yetersiz. Mars çalışması yayınlandı. Non-kardiovasküler cerrahide bridge yaptığımızda, ki bridge sadece %19'una yapılmış ve çoğunlukla heparinle çok az kısmında IV antiplatelet tedavi kullanılmış. Kardiyovasküler cerrahide bridge kötü sonuç vermiş. Non-kardiovasküler cerrahide bridge tedavisi başarılı gözüküyor. Yine trofibanla ilgili yayınlar var. Gerçekten DES implantasyonundan sonraki ilk 60 günde cerrahi gerektiğinde antiplatelet tedavi kesip yerine tirofiban kullandığımızda kısa etkili IV kullanılan antiagregan sonuçlar yüz güldürücü çıkmış. Hala kanıtlarımız eksik. Mono çalışmasının, monobridge çalışmasının sonuçlarını bekliyoruz. Teşekkür ediyorum. Sunumum burada bitti.
During the first year, we are very unwilling, to stop the antithrombotic therapy because the thrombotic risk is high. But thanks to the new generation stents, now we are now able to stop the dual antiplatelet therapy earlier than before. The question is in patients beyond 1 year, because all guidelines recommend going with single antiplatelet therapy, sometimes with dual antiplatelet therapy in patients with drug-eluting stents or with patients with coronary syndromes. So in clinical practice, there are a lot of patients coming to us who are scheduled for non-cardiac surgery and asking whether they should stop the antithrombotic therapy or not. And we know the thrombotic risk decreases with time, but there are very different subgroups of patients. Not all patients are the same. So actually, instinctively, in my clinical practice, I used to stop in some of them, and in some of them, I went on and insisted to the surgeon to do it under antithrombotic therapy, because we didn't have data. But thanks to Dr. Min Ahn and colleagues and Mutlu as presenting our country in this very nice designed trial, now we have some data, very inspiring data, and now Dr. Min Ahn will present us the Assured-S trial.
Thank you. Thank you, Chairman. I'm Jung-Min Ahn from Asan Medical Center, South Korea. My topic is discontinuation strategy of aspirin for non-cardiac surgery in patients underwent PCI. I'd like to introduce our randomized trial, Assured-S trial, collaborating with the Dr. Mutlu Vural in Turkey. Next, please. Okay, this is the most common job in my outpatient clinic, consulting patients with drug-eluting stent before non-cardiac surgery. One patient I suggest to stop aspirin, but the patient got a cardiac arrest immediately after operation. But one patient we suggested continue aspirin during the surgery, but the patient had a reoperation due to bleeding. So actually, this is a very challenging scenario to consulting patient with drug-eluting stent before non-cardiac surgery. We need some balancing between the thrombotic risk and bleeding risk. So in addition, it will be the important medical legal issue. In Korea, one judge decided that the hospital loses lawsuit because of a late notice on aspirin discontinuation before surgery, but the others criticized that no aspirin before surgery, doctor said, but patient died of heart attack. So it is a very important medical legal issue. So what is the guideline? I think the guideline is a very strong one recommendation to continue aspirin even after the 1 year after drug-eluting stent implantation. CCAH guideline, ESC European guideline as well. However, what is the clinical evidence? This is the one randomized trial to compare aspirin or no aspirin before coronary bypass surgery. In this study, showed that aspirin does not increase the bleeding risk, does not decrease the risk of ischemic event. But this population was a bypass surgery population. A PAUSE-2 trial enrolled the patient with a high cardiac vascular risk before non-cardiac surgery. They randomly assigned to the aspirin or no aspirin. The primary endpoint was death and non-fatal MI. There was no statistical difference between the two groups. However, major bleeding increased in patients with continuing aspirin. In this trial, there was one subgroup analysis who had coronary stent implantation before non-cardiac surgery. Total number is around 500 patients. It showed that aspirin use decreased the death or myocardial infarction by 50%. So aspirin group, the 1 month event rate is around 5%, and non-aspirin group, the placebo group, 1 month event rate is 11% of death or non-fatal MI, but major bleeding was not significantly different. Another interesting study was a Paris registry. Paris registry evaluated the step-dual antiplatelet strategy during the 2 years after implantation. They grouped three groups: discontinuation, interruption, and disruption. Interruption means that less than 14 days stopping dual antiplatelet under the medical doctor's guidance, doctor's surveillance. Of those patients, 70% of patients stop both dual antiplatelet. So the clinical outcome, interruption group, the lowest than other groups. So interruption under the short, brief duration of stopping dual antiplatelet under the medical surveillance would be safe based on the Paris registry. Another registry study showed that from Korea, Severance Hospital suggested that they evaluated their registry patient, particularly they compared the continuation antiplatelet therapy, discontinuation antiplatelet therapy. There was no difference between two groups. However, if patient discontinued the aspirin antiplatelet more than 7 years, increased the risk. Same groups enrolled another registry made a similar result. They enrolled around 6,000 patients, evaluated the continue versus discontinuation of antiplatelet therapy. Discontinuation of antiplatelet therapy did not increase the risk of major adverse cardiac event. More importantly, they found that only two patients out of 3,000 registered patients. So, based on this kind of equipoise, the clinical challenge in our daily practice, we designed a randomized trial. We call it ASSURE-DS randomized trial. This trial compared aspirin monotherapy versus non-antiplatelet therapy in stable patients with drug-eluting stent undergoing low to intermediate risk non-cardiac surgery. So up to 20% of patients undergoing PCI with DES need a surgical procedure within 2 years of coronary stent implantation. Patients with drug-eluting stent undergoing non-cardiac surgery are considered at high perioperative cardiovascular risk, facing competing thrombotic and bleeding risk. The guidelines recommend the perioperative discontinuation of aspirin in patients with drug-eluting stent undergoing non-cardiac surgery, even beyond 1 year after PCI. However, supporting evidence is limited, especially for contemporary DES. So we try to compare a strategy of continuing aspirin monotherapy versus temporarily holding or antiplatelet therapy before non-cardiac surgery. Temporary means 5 days before non-cardiac surgery. We hypothesized that continuing aspirin monotherapy could reduce the perioperative cardiac events compared to temporary holding or antiplatelet therapy at 30 years. This is a flow chart of ASSURE-DS randomized trial. So after 1 year drug-eluting stent implantation, patients come to outpatient clinic scheduled for non-cardiac surgery. Some patients on aspirin monotherapy, some patients on P2Y12 monotherapy, some patients on dual antiplatelet therapy. If a patient assigned to the aspirin monotherapy, antiplatelet will continue or switch to the aspirin alone. And patient assigned to the no antiplatelet therapy group, patient stop all antiplatelet before 5 days before non-cardiac surgery. After surgery, the antiplatelet therapy restarted as soon as possible, no later than 48 hours. So this is the normal criteria. Patient who successfully implanted at least one or more coronary stent more than 1 year before scheduled non-cardiac surgery. So we exclude the patient with acute coronary syndrome, unstable heart failure, and intolerance for aspirin, and who had the anticoagulation therapy and emergent or cardiac surgery, and very high-risk surgery, particularly intracranial surgery, intraspinal surgery, and retinal surgery. Primary endpoint was composite of death from any cause, myocardial infarction, stroke, or definite stent thrombosis. Next, please. So we try to enroll the 900 patients. So the heart centers from the 3 countries enrolled the patient. Thank you, Dr. Mutlu, enrolled the patient, actively participated, contributed our trial. Next, please. So this is the study flow. We screened the 2,300 patients. The enrolled randomization 1,000 patients, 500 patients assigned to each arm, but around 10% of patients did not receive non-cardiac surgery. Finally, we completed the analysis in 462 patients in aspirin monotherapy group, 464 in no antiplatelet therapy group. So patient age is 68. The 40% of patient diabetes, ejection fraction is completely normal. Chronic renal failure was around 8 to 10%. So this is the cardiac risk of patient and surgery. According to the revised cardiac risk index, the no risk factor is at 26%, and one risk factor is 43. More than 3 risk factors is 4% only. The cardiovascular risk of surgery, high risk is 11.9%. High bleeding risk of surgery was 12.3%. This is the PCI characteristic. A patient received the stent implantation due to stable angina in 40%, acute coronary syndrome 51%. This is very important. The duration from stent implantation. Our inclusion criteria is 1 year after stent implantation, but this patient actually enrolled the trial the 5 years from duration from the stent implantation to operation. First generation DS was implanted in the 11%, and 88% of patients received the second or newer generation stent implantation. For the first generation drug-eluting stent patient, the duration from stent implantation was almost 14 years. Yes, this is the primary endpoint. Primary endpoint, death, MI, stroke, definitely stent thrombosis at 30 days. There was definitely no difference between aspirin monotherapy versus no antiplatelet therapy. In aspirin monotherapy group, only 3 primary endpoints occurred, 0.6%. No antiplatelet therapy, only 4 primary endpoint events occurred, 0.9%. As treated group and per protocol analysis, overall findings are consistent. So this is in detail of patient with primary endpoint. Primary endpoint occurred in 7 patients, 3 patients in aspirin monotherapy group, 4 patients in the no antiplatelet group. In aspirin monotherapy group, 2 cardiovascular sudden deaths occurred, 1 myocardial infarction occurred, but this myocardial infarction is due to anemia, not the coronary event. The 4 primary endpoint occurs in no antiplatelet group. So 3 myocardial infarction occurred in no antiplatelet therapy group. The 1 myocardial infarction was related with heart failure. 2 myocardial infarction were the spontaneous myocardial infarction, but not related with the stent. Actually, no stent thrombosis in our registry, our randomized trial, and 1 stroke occurred 9 days after operation. So this is individual perioperative ischemic event. Death from any cause very rare, 0.4. Death, cardiac death, 0.4 in aspirin group, and no patient in no antiplatelet group. Cardiac death, 0.4%, and no patient in antiplatelet group. Myocardial infarction occurred in 0.6%. We evaluated the troponin I test in 283 patients. So elevated troponin I level after non-cardiac surgery, 23.2% in aspirin monotherapy group and 20% in no antiplatelet therapy. No difference between 2 groups. No definite stent thrombosis. Coronary vascularization occurred in 0.2%, 0.4%. Stroke occurred 0.2% in no antiplatelet therapy group. We evaluated the bleeding events according to the 3 different criteria: POS2 major bleeding, Barker 3-5 major bleeding, TIMI major bleeding. Regarding the major bleeding, regardless of criteria, there was no difference. There was no difference between groups. Regarding the TIMI minor bleeding, in aspirin monotherapy group 14.9 and no antiplatelet therapy group 10.1. In aspirin monotherapy group, minor bleeding significantly increased. And so the TIMI major or minor bleeding significantly increased in aspirin monotherapy group. We also evaluated net adverse clinical events composing of death, MI, stroke, definite stent thrombosis, or major or minor bleeding at 30 days. Aspirin monotherapy group increased the risk of net adverse clinical events, mostly due to the increase of minor bleeding in aspirin monotherapy group. So yes, I admit that the many limitations of our trial. First of all, this trial definitely underpowered to detect the difference between groups. Out of 900 patients, primary endpoint occurred only 7 patients. But I believe that it is really reflect the contemporary safety of contemporary second or newer generation DS and our practice. In addition, we underestimated the perioperative MI event because we did not measure in all patients, did not measure the troponin, cardiac troponin. But I believe that clinically relevant MI is more important than the biomarker elevation during when we consult the patient. And there are some limitations, even though in this patient undergoing non-cardiac surgery more than 1 year after PCI with the DES, perioperative ischemic event was very low. We found no significant difference in primary composite outcomes of all-cause mortality, MI, definite stent thrombosis or stroke at 30 days between aspirin monotherapy group and no antiplatelet therapy group before non-cardiac surgery. There was also no significant difference in major bleeding, although minor bleeding was more frequent in aspirin monotherapy group. Notably, no definite stent thrombosis occurred in both groups. This is our conclusion. In this assured DS trial involving patients undergoing non-cardiac surgery more than 1 year after PCI with a DES, a strategy of continuing aspirin monotherapy did not significantly reduce ischemic event compared with temporary holding all antiplatelet therapy before non-cardiac surgery. However, continuing aspirin was associated with a modest increase in minor bleeding. Given the lower than expected event rate and underpowered nature of a study, these findings should be interpreted with caution. Further research with a large-scale, adequately powered study needed to confirm the study result. Yes, this is contemporary guideline. So I believe that initially I planned this trial to change the guideline, but I think that we show that negative result between the two strategies, but the sample size is small, event rate is small. I'm not sure this trial will change the guidelines strongly, but I believe that the contemporary guideline does not have any clinical evidence. So in the future, we need more larger number the adequate powered study to evaluate it for this patient undergoing non-cardiac surgery, patient with a coronary stent before non-cardiac surgery. This population is, I think, the clinically very important population, and we need more evaluation study. Thank you for your rotation.
Thank you, Dr. Amin. It was really inspiring, and it's important for our clinical practice. As you said, it may not change the guidelines, but it will, I think, impact our clinical practice.
Yeah, I believe that.
And do you change your clinical practice, or are you going to change, or maybe you were not using, if you plan something like that, due to your observations?
Definitely, I changed my practice. Before getting known this result, I very hesitated to say that stop aspirin. But after knowing this result, I can say that particularly if my surgeon suggests not to take aspirin to patient, then I fully agree with the surgeon's opinion. And nowadays, I recommend the patient. I suggest patient not to take the aspirin before non-cardiac surgery.
Okay, I have prepared a few questions, but maybe Mutlu can contribute or ask something. Do you want to ask anything, Mutlu?
I'm wondering, Jung-Min, do you plan similar study for patients before 12 months of DES implantation?
Oh, this is a very important question, but actually, you know that it took 8 years to complete this trial. I think yes, we can do, but I'm not sure we could complete such a trial before our retirement. So anyway, that is a very important question. But before 1 year or before 1 year or before 6 months, definitely high risk population. So doing a kind of trial may not be possible, I think.
Okay, when talking about now the time period, what about the patients in the second year? Because there are a few patients after, between 1 year and third year in the second year. So most of the patients are beyond the third year. And as I looked into the data, there are a lot of patients on dual antiplatelet therapy when they are included in the study, and they went on dual antiplatelet therapy. So thinking of the time period from the DES implantation, why is it? Can we say these are, high-risk patients with complex, treated with complex techniques like bifurcation stenting, multiple, overlapping stent, etc.? Or how do you explain this? Because I rarely use, DAPT beyond 2 years. Yes, in few patients, yes, but this, percentage seems high to me, 1/3 of them.
Yeah, okay. This is another very important question. This guidelines suggest that many data suggest that the depth duration is shorter and shorter nowadays. So 1 year after DS implantation, many patients received a single antiplatelet. But in the patient, the multivessel stenting or left main stenting is composed of more than 20%. They may cause the high rate of death before non-cardiac surgery. In addition, depending on the cardiology strategy, if a patient don't complain of the bleeding or something, then many my Korean colleagues, my doctors, continue to do antiplatelet therapy even after the 1 year.
Okay, that's the reason. And another question is, did you make a subgroup analysis for those patients with complex procedures? Is it possible, or the sample size is too small and it's too low?
Yes.
And impossible?
So I do like to do many subgroup analysis, but unfortunately, event rate, the total primary endpoint only 7 patients. So further subgroup analysis is not possible.
So, Mutlu, any other questions?
I think you are very young and you can arrange a new trial for retirement for patients for 2 months to 12 months. Maybe it's not possible for less than 2 months after the ACE implantation.
I think a larger study, really beyond the first year, including more patients in the second year, and including a wider region, not only Korea and India and Turkey as one center, but a larger population, let's say worldwide, would be more easy to do, like a registry. Maybe. So we all are willing to participate in it if you plan something like that. And in summary, can we say, especially in those patients beyond the second year, we can actually have data now, although with limitations, stop antithrombotic therapy safely?
So the first of all, I would like to say that I suggested only 5 days. Recently, Dr. Mutlu, have you ever experienced stent thrombosis after 1 year stent implantation nowadays? Actually, very, very rare. So actually, our second generation DS or newer generation DS is very, very safe. But one condition, after surgery, surgeon ignore the antiplatelet therapy prescription, particularly due to after some complication, after gastrectomy and bleeding and stop antiplatelet, and discontinuation duration is more than 1 month and 2 months. One day, abruptly stent thrombosis, and they asked us to manage it. So anyway, stopping antiplatelet would be safe, but we have to say to our surgeons, please stop aspirin only short duration, and please resume after operation. So this is very important.
Okay. And one point is, there are a lot of abdominal and orthopedic surgeries. Probably they use low molecular heparin, at least at prophylactic dosage. Do you think this may have impacted the results?
So in this population, the low molecular weight heparin use is very rare. I believe that. But particularly if they use the low molecular weight heparin, the stop aspirin would be more safer than safer, I think.
Jung-Min, what do you use in your clinical practice to bridge antiaggregant therapy? IV antiaggregant therapy or low molecular weight heparin?
In the acute phase,
in patients before 12 months after the ACE implantation and non-cardiovascular.
Frankly speaking, I didn't do the bridge, actually. Personally, I believe that after 1 month, would it be safe? So after 1 month, I didn't do the bridging, but I cannot say in public because we don't have any evidence.
Okay, thank you very much then. Any other questions, Mutlu?
I think you maybe use antiplatelet therapy only for emergent surgery.
In the very early phase.
Very early phase.
Yeah.
Within 1 month.
Yeah.
Beyond 1 month, you don't advise any bridging therapy
Yeah.
for patients who treated with DS. Okay.
Yeah.
Thank you.
Okay, thank you, Dr. Min Ahn. Do you have any messages to your Turkish colleagues?
Yes, thank you very much for inviting me in this very big, important conference. So, as we did collaborated with Dr. Mutlu, so I hope the more collaboration with the Turkey doctors in the future. Thank you for having me here.
So we thank you for being with us and hope to see you soon live in Turkey, maybe for another symposium or conference. Thank you very much.
Yeah.